Well, good day, everybody, and welcome to PQA's final quality forum for 2019. I was very mindful to say good day because it officially hit 12 o'clock for me down here in Birmingham, Alabama. However, we have some colleagues from Kaiser over in Pacific time zones, and so it's still morning for them. Yet another panelist, Lynn from PQA, is over there in Rhode Island, so it's 1 o'clock for her in the afternoon. So it really is a good day to all of us here. We're really excited for today's presentation on polypharmacy. Optimizing care isn't always adding medications. And first and foremost, I do want to thank our sponsor for today's quality forum. This was brought to us by PerformRx, who has a 20th anniversary, so they have this really cool logo highlighting that. So thank you, PerformRx, for the support and helping us have our quality forum webinar series. For a few items within our logistics, during today's presentation, all attendees are in a listen-only mode. However, we still want to hear from you. So please use the question box in the control panel to the right of your screen to ask questions to any of our panelists, and I'll be sure to help facilitate that dialogue at the end of today's presentation. Today's forum is being recorded, and the copy of the slides will be shared with everybody. I think I'm just getting some chats to tell me I should share my main screen. There we go. Sorry about that. I'll go back here so everybody can see the PerformRx logo, 20th anniversary. As I said, you have questions on the control panel to the right, so go ahead and let us know about your questions. This is being recorded, and that will be part of the PQA members-only resource library in about a week. And at the end of today's presentation, we ask that you provide us any feedback and particularly any ideas for future quality forums. We're excited for what we have coming in early 2020, but we have a full year ahead of us. So speaking of what's happening in early 2020, on Thursday, January 16th, we're going to be having a presentation by John Gorman and Andrei Ostrovsky. They will be talking about opportunity zones and how this is a new way to approach social determinants of health. John and Andre presented at the Caring for the Whole Patient Social Determinants of Health Forum, which PQA hosted right before our leadership summit a couple of weeks ago. And we are excited to have them do a continuation of that presentation with us during a quality forum in January. So now I'd like to get into today's presenters because they are the experts and the people that are leading today's dialogue, and we're really excited for them to be here. First, we have Lynn Pezzullo. She's our Senior Director of Quality Innovation at PQA, where she's responsible for identifying and prioritizing new measure concepts and overseeing the subsequent successful development, testing, and endorsement of PQA measures. Lynn has a larger bio on our website, so I'm just going to pass over and go to our colleagues from Kaiser. We also have Lynn Deguzman. She received her BS in Chemistry and Biology from St. Mary's College of California and a PharmD from the University of California San Francisco School of Pharmacy. She served as the Clinical Operations Manager at Kaiser Permanente, Northern California since 2011. She leads the Pharmacy Medicare STARS program, which includes the Medicare Part D medication therapy management, medication adherence, stand use in persons with diabetes, and the polypharmacy and deprescribing initiatives. Finally, we have Kimberly Grant, who's joining us. She received her Doctorate of Pharmacy degree with a concentration in geriatrics from Duquesne University in Pittsburgh, Pennsylvania in 2015. She completed a postgraduate year 1 pharmacy residency with Duquesne and the University of Pittsburgh Medical Center. She went on to complete her PGY2 in geriatrics, also with Duquesne, and then also with the St. Barnabas Health System. She's currently a drug education coordinator and the P&T co-chair for Kaiser Permanente of the Mid-Atlantic states. We're going to have Lynn Pezzullo from PQA begin our presentation. So with this, Lynn, I'm going to mute myself and hand it off to you.
Okay, great. Thanks so much, Jake. I am really excited to hear about approaches that Kaiser Permanente is taking to address polypharmacy. But before I turn it over to Lynn and Kimberly, I just want to share some information about our PQA measures in this area. So within the domain of medication safety, PQA has these 3 measures that address patient safety in older adults. The high-risk medications in the elderly measure was the first and was endorsed by our PQA membership back in 2008. We continually look at opportunities for new meaningful measure development, and for the 2 newer measures, we began development in 2016, and the polypharmacy measures were then endorsed by our membership in 2017. These two newer measures that address polypharmacy in older adults, like the HRM measure, are also based on the American Geriatric Society Beers criteria. The Poly-ACH measure assesses the percentage of individuals 65 years and older with concurrent. Getting some background noise there.
Sorry for that brief background noise. Just a reminder to our panelists to maintain their mute. One moment, please, because I'm going to probably mute everybody. Lynn, I think we're better. Everybody, okay. Thank you for that slight audio adjustment.
Thanks, Jake. Can you hear me? Is my line still open?
Yes, you're still open and ready to go.
Okay, thanks so much. The Poly-ACH measure assesses the percentage of individuals 65 years and older with concurrent use of 2 or more unique anticholinergic medications. For both of the polypharmacy measures, concurrent use is defined as overlapping covered days for 30 or more cumulative days. This was developed as a health plan performance measure, and the rates are calculated using prescription claims data. As with other PQA measures, individuals in hospice care at any point during the measurement year are excluded from the measure. The AGS Beers criteria provide, just to share some rationale supporting this measure. The AGS Beers criteria provides strong recommendations based on moderate evidence to avoid concurrent use of 2 or more anticholinergic medications in older adults because of an increased risk of cognitive decline. Additionally, anticholinergic use in older adults is also associated with increased hospitalizations and decreased physical function. This measure is designed to improve quality of care across populations of patients, and the medication combinations included in the measure are those for which serious adverse effects have been reported in older adults. The next polypharmacy measure, Poly-CNS active medications measure, assesses the percentage of individuals 65 years and older with concurrent use of 3 or more unique central nervous system active medications. This also is a health plan performance measure that uses prescription claims data to calculate the rates. And again, individuals in hospice care at any point during the measurement year are excluded. Rationale supporting this particular measure, again, based on the AGS Beers criteria, that provides strong recommendations based on moderate evidence to avoid concurrent use of 3 or more CNS-active agents in older adults. And this is due to an increased risk of falls and for some combinations of these medications, fractures. As with the Poly-ACH measure, this also is intended to be a population-based measure and is designed to improve quality of patient care. And again, here the medications included in this particular measure are associated with serious adverse effects reported in older adults. So on slide 12, there was an AGS Beers criteria update published earlier this year, and this slide highlights the related changes to our PQA polypharmacy measures. So for the anticholinergic polypharmacy measure, 2 medications are added, pyrilamine and metscopolamine. And for the polypharmacy CNS-active medications measure, pentazocine will be removed. These changes will be in our next update to our PQA measure manual, which will be published in February of 2020. We also are testing other changes for the Poly-CNS measure, but they will not be included in that measure manual update. The changes being considered would include the potential addition of 2 medication classes, SNRIs and antiepileptics. These would be considered to be material changes, and so we are conducting testing around that. And then we will bring those results to our quality metrics expert panel for consideration and approval per our usual process for making any material changes to our PQA measures. And last but importantly, I would like to highlight the use of these measures in their use in the Medicare Part D quality programs. So the PQA HRM measure was a STAR measure from 2009 through 2017, and then was moved to the display page for 2018, 19, and 20. And CMS will retire that measure in 2021. And so as the HRM measure is being phased out, the two polypharmacy measures are being phased in. So the two polypharmacy measures, ACH and CNS-active medications, are included in the patient safety reports for 2019 and 2020. And then they will move to the display page for 2021 and 2022. CMS does new measures that are considered for STAR ratings need to be on the display page for at least 2 years, so that CMS can, assess and analyze their performance. And then CMS will consider these measures for the 2023 STAR ratings, which would be proposed through the rulemaking process. And as such, organizations are already focusing efforts and resources to address polypharmacy in these areas. And so I will use that as a segue to now turn it over to Lynn, so that she and Kimberly can share their insights and their efforts, and also to highlight some best practices that our audience will then be able to incorporate into their initiatives to address polypharmacy. Lynn, I'll turn it over to you.
Great. Thank you, Lynn P. Hi, everyone. This is Lynn. So next slide, please, Jake. So just to take a couple steps back, what is polypharmacy and why are we talking about it today? So in the literature, polypharmacy is defined as members taking 5 or more medications. As you heard earlier, Lynn did describe the other polypharmacy measures, which is 2 or 3 medications, but that's definitely evidence-based, which is why they chose those numbers. But in general, polypharmacy is patients taking 5 or more. There's a new terminology called hyperpolypharmacy, and that's members taking 10 or more medications. And another term that's coming about is medication overload. So all of these is just a term that describes that patients who are taking multiple medication, it can increase their risk for hospitalizations or hypoglycemia, which can lead to falls, cognitive decline, and death. And of course, with the medication overload definition, it's multiple medications for which the harm to the patient outweighs the benefits. So as our body ages, we're not metabolizing the drug as much. And so we really need to examine the medications for patients who are older than 65 to understand if they still need the medications and making sure that they're not having any adverse side effects with the meds. Next slide. This is just a pictorial view of what the U.S. Census Bureau is, estimating of the patients who are getting older. We could see that it's going to be 20% by 2030, which is actually double than what we've seen in the 70s, or even a 50% increase since 2010. So there is a huge need to really identify polypharmacy or medication overload in our members to make sure that they're safe and that their quality of life is better and that they're staying home, not staying in the hospital. Next slide. So I'm really excited that the World Health Organization has identified the third global safety challenge to be medication without harm. So if you're, just to recap, there are other 2 safety challenges that the World Health Organization has launched in the past. The first one was clean care is safer care, which is hand hygiene. So I'm sure a lot of you here in the industry know how well and how successful we've been in making sure that we have all the right materials to stay clean in the hospital. Their second safety challenge was safe surgery saves lives. So as you know, historically, this has been really successful where they've created surgical lists, countdowns. So it's very exciting to see that the third safety challenge has to do with medications. And I think polypharmacy, medication overload, and the PQA measures that just was described earlier today will really help drive this work globally, not just around the country. Next slide. So what is deprescribing? I've talked to a lot of different people as we launch this work in Northern California. Definitions varied between patients, prescribers, pharmacists, nurses, but actually the scientific definition, so to say, is that it is a planned and supervised process of dose reduction or stopping medications that may cause harm or are no longer beneficial. Thank you. And of course, there's guidelines now that are catching up to the literature, making statements on when to deprescribe or de-intensify medications. And some of the guidelines and evidence is a 2013 Choosing Wisely campaign, where it kind of summarizes drug classes that patients may not need as they get older. And there's deprescribing.org, which has evidence-based guidelines that Canada has been really put together. Dr. Barb Farrell's team has done a great job of really giving tools for everyone to kind of see what opportunities there are to deprescribe. And now the ADA and the Endocrine Society are starting to incorporate deprescribing guidelines or de-intensifying suggestions and advice on when we can stop medications in older patients. Okay, next slide. Oh, so now I'm going to pass the ball on to Kimberly Grant to talk about how and some barriers. So take it away, Kim.
Great. Thanks so much, Lynn. So thank you so much, everyone, for the opportunity to speak today. I hope my perspective can give spark some ideas or give some best practices on ways to kind of operationalize deprescribing, and I hope that I can provide some examples that might be helpful to your specific practice. My kind of practice comes from long-term care mixed with some hospital, mixed now with health plan managed care side of things. So hopefully you'll be able to take something helpful away. I kind of think at the highest level, deprescribing sounds really simple and really rational from a med safety perspective, from a clinical perspective. But unless you have a really well put together plan, it seems to kind of fall apart when you look into operationalizing it. So I hope today we can kind of give you some ideas to help put that type of plan into your practice, because that's kind of where the challenge lies, I find, in deprescribing as a whole. So, we know that deprescribing is kind of difficult in a clinic setting. You think back to physicians having about 20 minutes with a patient. When you think about this general geriatric patient population, we know that these are patients with 3 or more chronic disease states. Generally, thinking back to what Lynn mentioned, maybe 5 to 10 chronic medications. I mean, I've definitely seen med lists, 20, 25, 30 meds. And so to have, 20, 30 minutes to get through all that plus a chief complaint, deprescribing will kind of fall off the wayside. Although, we want to do what's best for the patient and promote that safety. It's really hard to manage kind of where to start deprescribing in the midst of all those comorbidities. And, kind of some feedback on the Beers criteria that a lot of people have had, or a lot of organizations have had, is that, it's not specific enough. It's really hard to target these patients. Who should I focus? Who's the highest risk that I should really focus on deprescribing? And so I hope in future slides we'll be able to give some ideas there as to who to focus on when you only have that, 20, 30 minutes. Ideally, we want to focus on safely stopping medications that are no longer needed, i.e. there's no longer a diagnosis for that medication or an indication. And then we want to monitor remaining medications to ensure safety. We'll discuss this more, but I think this is like the most basic crux of deprescribing, from a pharmacy student to a pharmacist to a physician, that we want to make sure that every medication has an indication and that indication is active. And then when you are starting a medication, what are you monitoring to ensure that it's working and to ensure that it's safe? Because that will give you your framework for how to deprescribe that medication later on if appropriate. So, A, is this an active medication for an active indication? If not, that is only going to lead to med errors, and so there's your rationale. And then kind of B, if the medication is present, how do you know that it's working and how do you know that it's not working? And we'll kind of give some drug level examples of those. But when we look to start deprescribing, the first step, when you kind of think of motivational interviewing kind of model, is to really break down the barriers that exist. And those barriers could be with the physician, could be with the patient, and could be with the patient's caregiver or family member. So there's really 3 people you need to be considering when you look to deprescribe these medications. And then the other biggest piece is to really engage in a inpatient practitioner discussion. There needs to be a shared decision-making model for this to really be effective. Sometimes that is a patient and a physician. Sometimes that is a patient and a pharmacist. Sometimes, the caregiver or the family members included in these discussions. And that discussion really needs to include establishing a diagnosis. So why are we using each one of these medications? Quantify that treatment goal. Why am I using each one of these medications? And then set a monitoring parameter. Like I said before, how do I know this is continuing to work despite my age-related change? And how do I know when to stop this medication? And so we'll go into those in the next slide. So I spoke broadly about breaking down barriers to deprescribing. We're not going to be effective, and it's going to be a waste of our time, quite frankly, if we don't work through some of these barriers, like I said, with those 3 different parties. These barriers are in the literature, and so hopefully I can give a couple examples of how these might manifest. The first is a lack of awareness, just a simple lack of awareness. A lot of times, kind of thinking back to that 20-minute model or even a pharmacist phone call or interaction at the pharmacy, whatever your setting might be, members don't have time or they really don't think to discuss their side effects, and we may not think to ask them. I kind of relate this back to just we're in a busy world, and we, if we're talking to them, we might have something else on our mind, like a chief complaint. We may not be asking about some of those chronic medications that just continue to be refilled, and we just assume that there's no side effect going on, no change in cognition. And so again, in a future slide, I'll kind of walk you through how some of those might manifest in actions that you can take. Another barrier that we commonly see is prescriber inertia. So essentially, prescriptions are just being automatically renewed even if an indication is no longer active. I think that one way that you might see this is if you have a nurse who's helping a physician with automatically renewing prescriptions. I imagine that the volume is quite large, and so there may not be time, quite frankly, to kind of look into, is this still an indication? Do we need to bring this patient in and discuss this? It's a lot easier to just automatically renew that prescription. So that's a barrier we really need to break down, and that's kind of like a change in thought process. Another way I see this is through specialists. So a lot of times you'll see a specialist starts a medication. I think in my head, a common example would be a PPI. And so because the GI specialist started this PPI 2 years ago, your primary care physician is nervous to stop it. And really you need to promote collaboration between physicians. I understand from my perspective that seems really easy because we have such a great integrated health record, and I understand that some of you may not, but that is something to consider, that if you have increased communication between that specialist and that primary care physician, some of that prescriber inertia may be able to be remedied. In terms of member and caregiver satisfaction, I think a lot of times with the geriatric population, when you talk about decreasing a medication or stopping a medication, a lot of family members or members can kind of view that as giving up. And that's really not the case. You really need to frame it as, I want to make sure you're taking the most safe and effective medications so that we can continue on a good streak, on a good, healthy streak, so you can live, long, long into your years. And I think that's such a common misconception that, just because I'm old, I'm going to have cognitive impairment, I'm going to fall, I'm going to have fractures, I'm going to be going to the hospital a lot, and that really shouldn't be true. We should be preventing those types of things through deprescribing and through appropriate use of medications. So I think that's a really just important philosophy to have. And finally, clinical apathy. If a member has taken a medication for years, why should I change now? It's so important to kind of educate on age-related changes. When we think of our ADME processes, absorption and distribution, you'll see a little bit of a change throughout the aging process. Where we really see the changes in metabolism and excretion with those changes in the kidneys, and then some change in liver metabolism. So it's really important to, speak to a patient. That education piece is so important to kind of drive that home, that I know you've been on this medication for 20 years and that medication hasn't changed, but your body's changing. And we might have to change the dose, the frequency, or change that medication altogether because of how your body's reacting to that medication and how that medication's reacting to your body. And we especially see this with anticholinergics, which I know will have a heightened focus in future years, as Lynn alluded to. And so we will break some of those down in some upcoming slides. So I spoke a little bit about engaging in that member-practitioner discussion. So this could be member, doctor, member, pharmacist. Feedback we've received from our physicians here was that they are absolutely wanting to support deprescribing and appropriate use of medications, but sometimes it's really hard, like I said earlier, to operationalize that. Like, what does that look like? What are some tools that they can use to help support pharmacy and our goals around deprescribing and around polypharmacy? And so some of their requests was simple, more educational tools that they can put into practice, more practical things that they can use on a day-to-day basis. And so we kind of use this discussion piece of, what would this look like with a medication example? And so the example I use is Zolpidem or Ambien. So essentially, why is this member using Zolpidem? So this could be considered for like a new start medication, or if you're looking to deprescribe a medication, you could kind of take this similar path. So first, why is the member using this med? You need to establish that diagnosis, identify that indication, and then set a quantified treatment goal. And this again should be collaborative with the patient, so everyone knows, here's the goal I'm looking to achieve with this med, and if it's not working, then we need to do something about it. So in the case of Z-drugs, I'm looking to see that it takes less than 30 minutes for me to fall asleep every night that I take this drug, and then I'm sleeping greater than 6 hours every night uninterrupted. I know this may not sound like a realistic goal, but at the crux of what do we use Zolpidem for, these are the quantified treatment goals. So setting that up in the beginning, then is this drug continuing to work or continuing to provide relief? What does that look like? Did sleep onset decrease, or did my total sleep increase? Going back to those quantified treatment goals that you set at the beginning. If it's not decreasing my sleep onset, if it's not increasing my total sleep time, then that to me means that this medication is not working. Now this is eligible for deprescribing or transitioning to an alternative. And another, thing to consider here, have they failed greater than one other pharmacologic agent? I think a lot of times, again, I understand it's very easy to go right to a prescription drug without trying some of those like OTC or like safer alternatives. And then also, are they experiencing any side effects? That's really your easiest way to promote deprescribing, because really if a patient's experiencing a dangerous side effect, then all the more reason to kind of almost immediately deprescribe that drug and make a plan for deprescribing that drug. So in the case of Zolpidem, do they have increased falls? Are they having increased confusion, any daytime sedation or drowsiness? That is kind of like a red flag to continue with deprescribing, getting rid of that medication off that profile. And potentially the most important to all of this, and kind of what Lynn and I want to drive home today, is that deprescribing is such a process, and that it continues on even at after a medication is stopped, and I'll hopefully show that in some examples to come. But you really want to establish that follow-up piece with the patient so that this is an ongoing process and not just a one-time thing, because if the deprescribing isn't working for them and now their quality of life's kind of decreasing, something's wrong there, and we need to remedy that with either a safer alternative or a non-pharmacologic option, or maybe bringing back that pharmacologic agent just for the interim to kind of help with the next transition. Again, kind of thinking back to that 20-minute doctor appointment, I think that sometimes we're not great at promoting the great services that pharmacy has that can serve as a framework for an appointment or framework for deprescribing. A lot of times, transitional events like a hospital admission, a move to assisted living for a period of time, or just simply a decline in status could prompt a full medication review by pharmacy. And I think sometimes our physician partners aren't even aware of that. And really reviewing some of those pharmacy notes from an MTM consultation or during that transitional event, a lot of transitions of care pharmacy models available out there that a lot of times those notes can give a really nice outline. As we know, number one is going to be my number one most important problem with the most rationale. And so kind of letting your physicians know that can serve as a great framework can be a great idea. Also trying to promote that every interaction with an older adult patient should be considered an opportunity for deprescribing, or at least reviewing that medication list and questioning some things so that they can go to their doctor, or you can intervene as the pharmacist. So any phone encounter, face-to-face electronic messaging when they're picking up at the pharmacy, if you are making medication adherence calls, if you're doing an MTM, if you're calling about another medication-related event, that you're always reviewing that full medication list and always looking for those opportunities and bringing them up as a question. Deprescribing shouldn't be limited to a geriatric service or a med safety service or like a deprescribing service. Really is for everyone to be cognizant of. So there's a lot of information on this slide, but again, I think it was really important when we worked with our physicians to be really collaborative in deprescribing, that you give examples and suggested actions. So these are not necessarily all anticholinergic drugs. I will kind of go through some of those examples in a future slide, but hopefully this can kind of show you like what might this look like in real life and what are some real life things I can do. I think a lot of times we as pharmacists tend to like a black and white versus a gray area. Unfortunately, a lot of what we find in geriatrics lies in that gray area where we know we don't have a lot of literature to support a specific tapering instruction. We don't have all this great patient level data of safe alternatives. And so it really has to be quite an individualized approach, which again makes it hard to make that overarching deprescribing plan in your individual setting, because we have such little studies and little literature that has a broad patient population. So a lot of times it comes down to a little bit of mixing what you find in literature with a little bit of common sense and a little bit of practicality, I find. So the first opportunity I highlight here goes back to my zolpidem example. This patient's using 10 milligrams at bedtime, but is getting up 2 to 3 times a night to use the restroom. If you've set those goals, those quantified treatment goals, this patient's not meeting that goal. And this was something I saw in my long-term care experience where this patient kept being prescribed increasing doses of the Z drug to the point that they were having 3 to 4 falls every night. Clearly that drug is not working. We need to have an action to deprescribe. So again, not meeting the treatment goal, let's deprescribe. There's a number of tapers you see in the literature for Z drugs for patients who have been taking them chronically. we tend to use 7 days a week to 5 days a week to 3 days a week if they are using that frequently. But again, kind of spacing out how many nights a week they're using this or how many nights a month they're using this medication sometimes is helpful when you don't have a lot of dose to play around with. You know, if they're on a 5 milligram dose, you might not have a lot of decreases in that dose to kind of play around with, versus you can spread it out over a number of days. And then I've listed some safer alternatives that we recommend here. Pantoprazole PPI is a huge issue, I think, and something you probably see in the hospital and might say, like, you know, if you work in that setting, this is just while the patient's in the hospital, or this is a more acute med, it'll be discontinued once they're discharged, and that is definitely not always true. And then it kind of hangs on for eternity, I find, and no one wants to be brave and discontinue it, or reach out to that specialist who started it. So again, remember, if there's no active or appropriate indication, we really need to consider deprescribing. Long-term use of pantoprazole can increase risk of fracture, Clostridium difficile infection, and vitamin B12 deficiency. Again, there's really no hard and fast evidence for one tapering approach over another, but again, we really like decreasing frequency to every other day, every 7 days, then discontinue, and you know, potentially using an OTC if needed, but really trying not to just simply replace the protonics with an OTC. Try to find out, why was this started? Do we still need to have it hang around? The next item I have here is butalbital for headaches. And kind of the example I give it is the patient's mentioning they feel tired and dizzy, and maybe it's due to their old age. I think this is really common. Again, back to that thought of, well, I'm getting older, so I probably will be tired and I probably will have some memory fog. Just knowing that that's not normal, and really telling our patients that and reminding them of that, and that sometimes deprescribing can really help them to live a fuller, more energized life. So just remembering kind of the old adage we're always reminded of, that any new symptom in an older adult should be considered a side effect until proven otherwise. Ask how often the patient's using this medication. Are they still having headaches? Maybe they're using more than a couple of times a month, and so that's leading to these increase in symptoms. Maybe we can give them more of a prophylactic medication for their headaches. Maybe it's another medication due to those age-related changes that's causing those headaches. So really becoming a detective on behalf of your patient. And then the final example I give is surrounding Paxil. I think this is a medication we found that not a lot of our providers even realize how highly anticholinergic paroxetine is. And because of its short half-life, if a patient's on a dose greater than 10 milligrams a day, they can be at risk for significant discontinuation syndrome. That can include some really terrible things: nausea, vomiting, excessive sweating, lightheadedness, flu-like symptoms, even going on to mood swings, ringing in the ears. So for this one, it's very crucial that we are using an appropriate taper. And there are multiple in the literature for paroxetine, and they really suggest using some additional supportive measures, having the patient keep some kind of journal, encourage exercise as much as possible, promoting a balanced diet, avoiding excessive caffeine and alcohol intake, and using some stress reduction techniques. We have a couple just simple, like, relax and listen meditation kind of programs that can help support titrations kind of in this area, you know, whether you're using for depression, anxiety, or vasomotor symptoms. And, you know, here for paroxetine, I think that there's a lot of really fine alternatives in this case too. And so when we have so many other agents in a class that we can use as far as SSRIs, why not? So hopefully this gives you some ideas for things to look out for, some alternatives, and ways you can kind of take a real life scenario and put deprescribing into action. Now we just wanted to focus the last bit of our presentation on deprescribing in light of these new measures, really focusing on polypharmacy and the multiple anticholinergics. What's really great about these new measures, if you think about it, is that it's really providing a specific scenario that's linked to negative outcomes. We know that using all of these medications in combination can increase healthcare costs. It can also increase adverse drug events, and this is well documented in the literature, especially for cognitive impairment, falls, and fracture. And also with anticholinergic medications, we know that there's this dose-response relationship that will show a higher burden of anticholinergic use consistently shows a negative association with cognitive performance. So I really think that these new measures, while they might seem broad, I really think they're less broad and blunt than the previous measures where you may be, targeting a patient that's not necessarily your most high risk. And I would say a patient on, greater than 2 anticholinergic medications who's older than 65 is definitely considered high risk to me. So in terms of some medications to target, and not all these medications listed here are anticholinergics, but I'll kind of let Lynn talk about her diabetes work, which is so important. And I think to remember here, of course, we want to support new measures, but we also want to make this more of a philosophy that if a medication is not having an active indication and is not helping to treat the patient's disease state and is causing more harm than good, then we want to work to deprescribe that. And having that general philosophy is really vital to having a successful outreach, right? And so I just kind of gave some examples of some drug classes for the anticholinergics, so antihistamines, skeletal muscle relaxants, the antimuscarinics, antiemetics are really some areas that you're likely going to be focusing on. Antihistamines, I really think that patients don't understand. Anytime I have a conversation regarding an OTC sleep aid or like a Tylenol PM type product, or even like a cold and flu product that they're maybe using but not telling their pharmacist or physician, and they may be using quite regularly, that may have Benadryl in it or another antihistamine that really may lead to some cognitive impairment. And I find that patients, their caregivers, and physicians are pretty shocked by that. So that honestly could be like an easy medication to target, an easy conversation to have. Skeletal muscle relaxants, I find a lot in practice, are really just sedating versus treating the patient's pain. So really having that conversation of describe your pain to me, what is helping, what is not helping, really could give you some rationale to deprescribe those skeletal muscle relaxants and maybe turn to more of a topical, even OTC agent for that class of medications. Antidepressants I talked about before. There are truly so many alternatives here. And so while there might be a lot of supportive care that's needed in terms of tapering, I think it's kind of an easy area to target in a way. None of this is easy. I do understand that, but I think it could be an area where you at least have some studied alternatives. In terms of antimuscarinics and overactive bladder medications, I think these can be really hard sometimes to deprescribe, but really looking at when these prescriptions are being renewed or when they're being started, as soon as the patient has a worsening side effect that we think is due to a medication, it needs to be discontinued. If there's no, and then working to taper that medication. For OAB meds, you can consider weaning by like 25 to 50% of the total daily dose over 1 to 4 weeks. Unless it's a very dangerous side effect, you really don't need to be absolutely urgent with this. You can take your time so the patient, the physician, and the caregiver all feel comfortable. And as you wean, check in with that patient. If there's no additional side effects, keep weaning, keep titrating. And if those bladder symptoms come back, go back to that lowest previously tolerated dose where they were having some success and kind of start again. Again, this is kind of a continuation, making sure that you establish that follow-up we talked about earlier. So this is deprescribing as a process and not just a one-time thing. Know that when you really get down to some of those final titrations, they can be drawn out over weeks or months to really make sure that everyone feels comfortable, the patient's not having additional side effects. Again, like I said, sometimes in terms of dosage forms, it's hard to decrease the dose. It might be easier to increase the interval. And then looking at things like antispasmodics, antiemetics, a lot of times, again, these one-time or as-needed medications get left on the profile and they're really never addressed, and we don't quite know unless we ask how often is the patient using this. If they're not using it at all, it's simple to get off. And if they are using it a lot, let's get to the root of that problem and how can we help with that chronic disease state, or how can we look at some of those other medications that may be causing that. All right. And then my last slide before I turn it over to Lynn, just how to operationalize deprescribing. We've worked with educational detailing to providers, showing them what I've showed you, specific drugs to target, tapering schedules. They find those practical tools really helpful. Patient education can look like letters, bag stuffers with a prescription, mailing, or a secure message. A lot of times we find, and I've seen this in the literature as well, that patient education promoted by pharmacy is great, but you really need to kind of have that physician primer with the patient to be really effective. So even as simple as a physician saying, hey, a pharmacist is going to contact you in the upcoming weeks to talk about some of your medications can be really helpful to the patient kind of signing on and being a part of this deprescribing process. So thank you so much. I'm going to let Lynn kind of wrap up and talk about her learnings with her service around deprescribing.
Great. Thank you, Kim. So just to summarize Kim's work as well, and Lynn Pezzullo's talk, is I think the PQA Polypharmacy Measures is a really great way to start the discussion of polypharmacy and deprescribing, and it definitely is a culture shift. So I think the PQA Measures is a great starting point, and as you start to engage with your prescribers and your patients on the CNS and anticholinergic agents, and it's definitely a good way to kind of segue into other medications such as the diabetes and the nonsteroidals or hypertension medications, which is detailed in the Choosing Wisely guidelines. So just kind of summarize all of those things. And then I wanted to share our system learnings. So again, some learnings to operationalize the work. And I know we want to leave some time for Q&A, so I'll kind of speed up through this part. We definitely wanted to create standard documentation workflows, so we're not going back and forth through the medical record and deciphering different data elements. We were able to really consolidate our resources centrally. We did create a SharePoint site for everyone to look at all our Kaiser regions, that they can see, deprescribing evidence, guidelines, what different work that we're doing here in Northern California. Definitely really try to embed in your culture performance improvement foundation. We did learn a lot through the work with deprescribing and polypharmacy, and had to do really small tests of change to find out what works for our prescribers, what works for our patient, what's the right scripting, how should we approach this. So we had a lot of those different kind of different workflows happening as we were really trying to broaden the message. And every system, it does have a platform that you can use to share your message. Find out what those are and get yourself in those meetings. If there's an opportunity to create a CME for your physicians, to just have them be aware of what is polypharmacy, what are the risks of that. That would be an ideal way, a starting point. And then also with that, be really cognizant of quality measures, which you are as you are dialing into this phone call, with med adherence, the polypharmacy measures that PQA just announced, and other future metrics. How do we kind of synergize with those metrics versus going against them and negatively impact them? Okay, and next slide. And so some key learnings is, and you're starting that work today as you're dialing into this, is let's start to live and breathe deprescribing. How can we continually obtain passive or active buy-in at major regular meetings throughout your organization? Don't be afraid to become that point person, that subject matter expert on how to deprescribe. I think conceptually we know that taking a lot of medications can increase side effects. It also can decrease adherence. It's hard to keep track of taking multiple medications. So how can we start to embed that into our culture to just be part of our work? And so So, I really challenge you all here to do that. And really, let's publish your work. I think there's definitely a lot of evidence out there of what is polypharmacy, what are the risks of polypharmacy, but how do we do it? How do we operationalize it? And that's always kind of the key question. And let's normalize that topic as we move forward. And today is definitely a great starting point. So thanks for dialing in today. And, let's start. I challenge you with one simple initiative, gather 5 patients, evaluate, discuss, see how we can incorporate deprescribing protocols or guidelines within your healthcare system with just those 5 patients. So thanks again for the opportunity to share our learnings with you here on the phone. And thank you, PQA, for having Kim and I attend and lead this work. So hopefully we have enough for a couple minutes for questions.
Yeah, well, Lynn, and Kim, thank you very much for a very exciting and timely presentation that definitely intersects the population health of PQA quality measures with direct patient care. So this was really helpful, and we do have a lot of questions for us. A couple of the questions did ask again about the recording. So just as a reminder, slides and recordings will be available on the PQA member resource library about 1 week after today's presentation. So the first question, I might kind of kick to Kim based on your experience, but how do we best promote adding indications to prescriptions? I'll say that from that long-term care perspective, the SNFs or our skilled nursing facilities do have that as a measure where we make sure that every prescription has an indication, but we don't see that in community pharmacy. So how can we empower physicians and community pharmacists to really get that indication, given so much emphasis that you put on it and it's needed for this deprescribing?
Yeah, thank you. Unfortunately, there's no straightforward, simple answer. I think a lot of times the indication piece, if you don't have access to that health record or you don't have access to some of those notes and you don't have the time to sift through all of that, it can be pretty difficult. I think don't be afraid to talk to the patient. They have a lot of information we don't always tap into. If they have any kind of like transitions of care notes, if they've just been transition from the hospital, or if they have like a provider note from an appointment, kind of reviewing that medication list and that problem list together. But I understand it's kind of this like global, long-standing problem. But I think my kind of recommendation there would be don't be afraid to ask and have some dialogue. I think all of this, you have to be collaborative with the physician and the patient and potentially even the caregiver if that's the case. And they have a lot of information that we don't always ask about.
Perfect, thank you. And Lynn D, I think this next one can kind of get punted to you, thinking about strategy and organizational initiatives. A lot of what we talked about today focused on the polypharmacy for anticholinergics. Have you had any success or initiatives focused around the polypharmacy CNS depressants?
Yes, so it's very similar to what Kim is doing at her region at Mid-Atlantic States, but it's very just providing provider education and pharmacist education on, what the side effects are, what is the risks of having multiple medication, and work collaboratively with your providers to identify opportunities on who are those patients that we can deprescribe or stop those medicines. And of course, to circle back is always, talking with the patient, also providing them education on why it's important to consider stopping these medicines as they get older. Their bodies are not metabolizing the drug as much, and so their risk for getting dizziness or falling is higher when they're taking the multiple medications. Again, so I guess hopefully that answers it, but I guess also to try to have it apply to your healthcare system is, we did get in a room together with pharmacists and physicians and really kind of brainstorm on what is that particular population that we could target. And again, as the PQA has done for us. They've kind of did the heavy lifting for us. So to use that as a foundation, that measure that they've developed, and identify how many patients from your health system meets that criteria, and then present that to the physicians. And I think they'll be surprised at the numbers that they see. I think a lot of our physicians think that, oh, our patients aren't taking that many medications, you know, they're doing well on what they have. But when you really show them the power of the data, that actually we see X amount of patients taking three of the CNS agents, 2 of the anticholinergics, or, you know, they're very surprised to learn that it's such a high volume. And with that, that definitely drives discussion on how can we reduce this number of meds in those patients. So hopefully that helps.
Perfect, thank you.
Yeah, you're welcome.
Lynn P., I'm gonna ask you this question, and I'm going to tell you to do it in 30 seconds or not, less. And you're going to love what the question is when you hear that roll. So the question came across talking about how can or what can standards development organizations like the Script Standards for NCPDP or HL7 for Pharmacist Care Plan help with shared describing clinical decision support with prescribers. So really, I'm going to translate that into, can you just touch upon what PQA is doing in regards to interoperability?
Okay, so I think
again, 30 seconds. Not that that's a fully loaded one.
Yeah, thanks, Jake. I was just going to say you kind of shifted the question at the last minute there, but so as far as our efforts around interoperability, we will be launching a new group early in 2020 focused on data and interoperability, and that the primary goal of that group will be to help support the data needs to develop future medication use measures. So we look forward to launching that group, and we will have some communications coming out in the near future around a call for nominations for our membership to get involved and participate on that group.
Perfect. Thank you, Lynn P. And so again, being mindful of the transition of people going to one meeting to the next, I'm just going to do one last question. This is going to go back to Kim. And Kim, you gave many examples about kind of engaging with patients and talking about how their body changes, even though the drug dose might not change. But do you have any other tips and tricks for the audience on how to empower patients and caregivers who question or don't understand these prescribing efforts?
Yeah, I mean, if you look at some of the data, I think Lynn gave it earlier, but we have such a large aging population. And so really the target goes from we want patients to live longer. We're there. We want them to live longer and be healthier. And I think when you talk about that as a goal, that just because you hit that age of 65, nothing should really change. We just need to adapt the medications that you're on to the changes that are happening in your body, whether that be a decrease in renal function or a change in liver function, and letting them know that getting old isn't a bad thing, and that we're here to help you, and that pharmacists can really do a lot. I feel like a lot of patients know that, but knowing that they can proactively come to you versus you always asking, I think is really important to continue to build on that trust, and to kind of take that approach with the caregiver as well. Yeah, I hope that helps. It's hard. I know it's hard, but yeah.
Well, thank you very much. So now jumping back to our slide presentation. Again, we want to thank you for attending today's webinar. We want to thank our sponsor, PerformRx. We want to thank our speakers, Lynn, and Kim. And then we want to say, keep in touch with us at PQA. You can see some of our contact information there. And don't forget, we hope to see you in 2020 with our next quality forum on January 16th on Opportunity Zones with John Gorman and Andrei Ostrovsky. So again, thank you very much for joining us, and I hope everybody has a wonderful December, and we look forward to seeing you in the new year.
Great. Thank you, Jake. Thank you, Lynn and Kim.
Thanks all. Bye.
Bye.